Hello, it's a pleasure for me to talk about what I feel is one of the most exciting treatment options that are available for CF patients in the many years that I've been involved in cystic fibrosis, and that's the medication called Trikafta. I suspect that many, if not all of you, are aware of some aspects of this medication, but I'd like to take this opportunity to go over and address some of what we call frequently asked questions, or FAQs, about this molecule. I think I'll be known to most of you who are listening to this, but for those who don't, my name is Dr. Pearce Wilcox, and I have the privilege of being the adult CF clinic director here at St. Paul's Hospital, UBC. So, what is Trikafta, and why is all the excitement that's been generated about this? Trikafta is something that we would term as a CFTR modulator. So that begs the question, what is CFTR? And that's a big long word, cystic fibrosis transmembrane regulator. And essentially, that's the protein that goes wonky in CF. So the mutations lead to either no or a minimal amount of the protein being produced, or the protein that is produced doesn't function properly. So this CFTR, as you're probably aware, is primarily what's called a chloride channel. So it's a protein that the body makes that moves up to the surface of cells, many different cells in the body, but we focus on the lungs, but essentially in many different areas that you've been aware of that are affected in CF. But the protein sits on the cell and works to control the amount of chloride that goes out of the cell. And that's very, very important in getting the right amount of fluid on the cell surface, really crucial in clearing secretions and having its role in protection of the lung. So when that protein does not function, then you're left with the results that we all are aware of in CF. So how does this drug, this Trikafta, affect that? And it's complicated, but it works, and I think it's important to emphasize, and I'll come back to this, that it works for those individuals who at least have one mutation of the most common mutation that we call F508del. At least 90% of our patients in our clinic have one or two of these mutations. So the Trikafta, the tri in tri is three. So there's actually three different medications in Trikafta. And the problem with the F508del mutation is that the cell actually produces the protein, but because of the mutation, there's a real problem of the proper folding of the protein. And the protein doesn't fold properly, it doesn't look properly, and the cell has its own internal system to determine if the proteins are abnormal, and it detects this as an abnormal protein and breaks it down. So very, very minimal, if any, amounts get up to the cell surface. So what two of the compounds in Trikafta do are so-called correctors. So, we don't know exactly how, but they bind to the protein and they somehow lead it to fold more in a normal manner. Maybe not completely normally, but more in a normal manner. So that then the protein, a lot of it escapes this internal regulation system, and the protein, more of the protein anyways, gets up to the surface. So another issue, though, with this F508del mutation is that even if it gets to the surface, that the control, the opening and closing, it's like a gate being opened and closed, doesn't work properly. So there's the third medication in this Trikafta, ivacaftor, helps to open up the channel and allow more of the chloride to go out and more of the fluid to be formed properly. So an interesting mix of three different compounds. So I think the next question is who would be eligible for Trikafta, and I think, as I mentioned to you, it works on this 508 del mutation. So individuals with at least one of those mutations would be potential candidates for Trikafta. Now, as I said, that makes up around 90% of our population, so the majority of individuals, and it's been studied pretty extensively. As of yet, there have been relatively few studies in children, so at least in Canada, so far, it's not approved for anybody under 12 years of age, not an issue for our clinic. It is possible that when the government comes to considering who will be paid for with this medication, and that's a complicated situation that I'll address further, but it's possible that there will be some additional conditions that will be placed under access. We just don't know that. We're hoping that that's not the case, that, for example, those individuals with mild lung function would not be provided, because we do believe that even in the mild sense, if there's not much damage, the important role of this medication is to protect and prevent more damage from occurring. So we're very hopeful that there won't be a regulation based on milder disease, but the reality is that we're going to have to wait and see.